Did you know that women of childbearing age, including pregnant and breastfeeding women, are routinely excluded from clinical trials? This results in that 90% of medications that are approved today lack specific data for these group of women. Welcome to the Women's Health Uncovered podcast. I'm your host, Mariam Harutyunyan, and in this podcast, I sit together with doctors, policymakers, industry leaders, and change makers to bring you conversations that matter about women's health, so you can learn more about this topic and also why it impacts all of us. I also want to thank my partner FTI Consulting for supporting us on this journey and making this podcast a reality with us. Today, we will discuss a little bit more about the gender data gap together with my two guests that I would love to introduce to you right now. Welcome, ladies.
Hello. Thank you.
My first guest is Marie Teil. She's the head of UCB's Women of Childbearing Age program and co-chair of the Bridge Commission. Welcome.
Thank you.
I'm going to ask you one quick question first before we dive into it. In one word, what drives your mission to close the data gap?
Passion.
That's a good one. And a clear one as well. My second guest is Maha Ganem. She's a journalist and public health researcher whose own healthcare journey inspired her work, if I'm correct.
Absolutely. And
welcome.
Podcast host.
And podcast host as well. What's one word that captures your experience navigating the healthcare system?
Shock.
Do you want to elaborate on that? Why do you choose that word?
In one word. Well, that's actually, I'm still a journalist, and my specialty is the geopolitics of the European Union. Mm-hmm. So geopolitics is about power, shift and struggles and relationship, right? I did not expect to find that in the healthcare system when I got sick. And that's what sprang me on a new path with my life and with my career. And so I was shocked to see this kind of, power dynamics and power shifts. And yes, a lot of power happening there. So I was shocked.
You mentioned your personal story. I would love to hear about that in a minute as well. 1 in 2 women will be diagnosed with a chronic condition in their life, but most medications were actually never tested on them either. Only in recent years have women's voices as patients, caregivers, and researchers started shaping mainstream healthcare narratives. Now, I want to understand what brought you also in this field. Marie, you lead UCB's Women of Childbearing Age program. Can you tell us what it is about and what inspired you to lead that program?
Absolutely. So I'm going to start by what inspired me.
Yes.
Because it's both professional and personal. And I worked in the US for a couple of years, actually 15 years. It's a little bit more than a couple. And as part of that, I'm a physician from training. I was in research and I was seeing a lot of patients. And among these patients, a lot of them had a chronic disease, a chronic condition. And a lot of them were struggling and asking about, what am I doing? I want to have a family. They were young women wanting to have a family. So we didn't have the answers for them. We didn't know. I saw a lot of these women deciding not to have a family because of that. But more personally, on a personal level, I have a friend, but at the time she was a lot younger and was in the same situation. And after finally deciding to get pregnant, she didn't know how to manage their disease. We were not able to give her the information she needed. And she lost her baby. And she she was in a very, very serious condition.
And which disease is it that she was suffering from?
It was a gastrointestinal disease, chronic disease. And so a disease where you need to manage it and can be life-threatening. And so...
And that's also in link with, the program that you're doing now.
So, exactly. So when UCB contacted me and asked me to how they could improve data and generation of data for some of their drugs, for women of childbearing age, it was a no-brainer. I basically accepted very, very quickly. And this is how we built the Women of Childbearing Age program.
What does it include?
13 years ago. So we started very small and we look at data we look at how we can generate data, what we have on our assets early on. So really early development. What do we know about the assets? What are the risks? And then we start talking to patients. What do you need? What type of information? And we always talk about women of childbearing age in general, but actually everybody has its own questions and its own needs. And not all diseases behave the same during pregnancy. Some actually feel better. So pregnancy should be a good thing for a woman, for the disease and the management. Unfortunately, in autoimmune diseases, which I know we're going to talk about, very often women need to continue managing their disease. And so out of that, what type of data do they want to see to inform them and their healthcare provider to make a better decision?
Yeah, thank you for sharing that story. Because also for you, Maha, your personal health journey started a decade ago. Can you tell us first about that journey, what led you into this, but also when did you realize something fundamental was missing in how women are treated in medicine? That came also from your personal experience.
Absolutely. So what you said right now about your friend, I absolutely a lot of words came to mind and about my own experience. So one day I was here in Brussels in my bed and I woke up in the morning and I came to, when you push away the cover and you're going to get up and start your day. Well, it did not happen. I opened my eyes, my brain was on, but I just couldn't move. I can laugh about it right now, but at the time I was like, whoa, what is happening? I thought like there was like a bug in the matrix or something. And so fast forward a few days later, I've seen a doctor. We did all kind of tests, etc. And a few months after that, actually, I was diagnosed with sarcoidosis, which is a autoimmune disease, like a lot of women have, that affects brain, heart, and lungs. And so during this whole thing, the only option I had was to take high dosage of cortisone. And cortisone, well, it's good and we do produce cortisol, right? To this fight, flight, or freeze response, which is something that preserves us and it's good. But when you take it in high dosage, it actually has an effect on your bones. It has effects on your mental health, and it has an effect also on your weight. And so doctors, they told me, then you need to see a nutritionist and you need to see this type of doctor and that type of doctor, because when they start with their diagnosis, in my case, I was very lucky. They did not stop. They found 3 other conditions and I was like, are they treatable? And they were like, no, they are what they call idiopathic, which is medical term to say, we don't know where it comes from. And not because we're not interested. Well, because there's not enough research for it, because there's no money in it, right? Because there's not enough people, because it's a rare disease, what I have. And so that was my first shock. Well, the first shock was the way the first pneumologist told me about it. Like he said, okay, this is your prescription for cortisone. You have sarcoidosis. Please set up your 80 euros at the front desk and see you never.
Yeah.
So that was the beginning.
The information that you received, or even the type of care. It seems like there was a lot of lack in that.
No care at all. And I was like, are you for real? And in France, the healthcare system is a thing, right? It's an institution, in every sense of the word. And so when I got sick, I was like, okay, I'm going to be taken care of, right? It's the French system. We're supposed to be the best healthcare system in the world. Spoiler alert, we're not. And definitely not when it comes to taking care of the human beings, basically. We are a great system when it comes to take care of the disease and more specifically of the organ that is diseased, but not really when it comes to take care of the person, and definitely not as a whole. Yeah. And you're not even seen as a human being, I would say. So that was my first shock.
Yeah. And your story continues because you've been on both sides as patient, but also as caregiver for your mother.
Yes. Oh, yes.
What did you learn from being on both sides of the healthcare system?
So many things. But I would say that the biggest takeaway is that, again, it's not the people the patients that are at the heart of the healthcare system in France and in most Western countries. You have the goals of the healthcare system are not the goals of the healthcare professionals, which are not the goals of the patients and which are not the goals of the caregivers. And so you have 4 sets of people with 4 different kind of goals and 4 different kind of expectations.
Mm-hmm. And no alignment in...
And they do not align. As a patient, you want to go back to your old life, right? Which, again, spoiler alert, will never happen. As a caregiver, what you want is help and support. In supporting the person who is sick, again, you don't get it because that's not what the healthcare system is about. As a healthcare professional, well, you just want to get through the day, basically, because I've talked with a lot of them. And as a healthcare system, as a state, what you want is a balance between cost and benefit, basically. So you need to have a certain percentage of the population that is in good health, in good shape, so they can go work, so you can get that GDP. But you also want them to also be consumers, and so they need to be able to go out on the weekends, etc., etc. And so all those goals, they don't align, and all those goals sometimes they are even at odds. And at the end of the day, the main goal is the one that of the state is not what we call PROM, which is patient. Patient recorded outcome measurements, which is what I'm also fighting for.
It's actually really crazy because you have first of all, the not alignment between the different groups. I hear in your story also that you didn't receive enough information, and then you have the idiopathic diseases because they're rare. There is not enough data around it. There is, in general, not enough data about women's health. There is less than 0.4% of clinical trials submitted in the EU include pregnant women, and the number drops when we're talking about breastfeeding women to 0.1%. Worldwide, even fewer than 1% of study participants are in childbearing age. So they're not even included in these trials, let's say pregnant women. And over 50% of trials still explicitly exclude them. So there is a lot of work to be done in that area. But now, before we dive into that, because we want to talk a little bit more about the gender health gap, etc., let's define it first.
Oh my goodness.
It's a challenge, but Maha, can you help me in defining the gender health gap clearly? Like, what do people not understand about how women are being excluded from data? How does it impact daily lives? What do we need to know?
So what we need to know is that everywhere, wherever you live, in Belgium, in France, in Europe, in the US, there is a story about what the healthcare system is. That is very important to understand. And that story is that the healthcare system is for all, that the healthcare system is equal. So you have equality, and that is scientific. It's not true because, again, when 50% of the population, in some countries women make up 52% of the population, are excluded from what we do when it comes to research, when it comes to gathering data about the human body, about what is health, what is disease, how the organs, how the hormones work. When already half of the population is excluded, you can't call yourself scientific. And that's the story that we are being told, and that's the story that we are being sold. And when we talk about gender gap, yes, numbers, we need to know them, but what we need to understand is that it means lost pregnancies. It means lost opportunities when it comes to achieving your goals. It means loss of opportunities to get the right care. It means people that we do tell some women you are sick, and then they undergo treatment, and in the end, miraculously they're cured, but in the first place they were never sick, so they were misdiagnosed. And some women, like in endometriosis, which is now more known, they can wait from 7 to 10 years. And from 7 to 10 years, they suffer in their body monthly. Some, when they have their period, it goes until they faint on their period and they can't get out of bed. They just lie on the floor. So gender data gap means that actually your life is hell and your health makes you suffer when it shouldn't.
And it impacts all of us.
And it impacts absolutely all of us. It impacts the children of women who have children. It impacts your social relationships, which is like the most important determinant in health. It impacts your capacity to make a living. which is kind of important, and especially in capitalistic worlds, it impacts your confidence, and impacts what you think you are worth and your self-worth. Because when a system tells you it's in your head, when it's not, because it's just we lack the data, then what do you think about yourself? How do you live with yourself?
That medical gaslighting.
Oh my God, absolutely.
Yeah.
It's real, and it impacts all women every day, everywhere, whether it's just you or it's a sister or your mother or a cousin. And basically the patriarchy is silently but slowly killing us.
I'd love to get there in a bit as well. But Marie, why are women excluded in research?
So I'm going to give you some data.
Yes, please.
And some dates. Because I think we need to ground ourselves in data. As we keep saying, missing data. 1986, it's the first time NIH, the National Institute of Health in the US, encourages women in clinical trials. Before that, they were not even encouraged. So you think about it, 30 years ago. And 10 years later, a little less than 10 years later, it became mandated. So it's US Congress passed a law to mandate the inclusion of women in federally funded medical research. So great. We're still here, though. We're still hearing you.
Yeah. Did we make any progress?
We did.
Okay.
And I just want to say we did. It takes time. It's a change in mindset. It doesn't happen over time. But we were under the assumption that studies in general, men and women, would behave the same way in clinical trials. And so the data that were generated were mostly generated based on male, as you said. And the reason was that male were participating in clinical trials and not women. And so I think the mindset and what's going on for the last 20 years is that we've been encouraging women to participate, but it's not easy.
No.
Right? So it takes, and we need to take into consideration something that we missed in the past was taking into consideration the biological and physiological differences between men and women, which now we know how to do. So there is hope. It's happening. It takes time. It doesn't happen overnight because you need to collect a lot of data to get there and to get to a point where you have the information you need. This is even more true for pregnant women.
I want to highlight some things you said. First of all, you know, when it was encouraged to include, it didn't happen until it had to happen. So let's be clear. When it's just left to goodwill, it doesn't always bring a change. Well, doesn't always, most of the time it doesn't, unless people have to do something. That's important and in other areas as well. Second, what I want to continue on, you mentioned, the historical data, which is quite important to look into. Well, historically, the fear of legal liability has been a major barrier when it comes to including pregnant and breastfeeding women in trials. Okay, there is one famous one that most people know. It's the thalidomide disaster in the 1950s, which caused birth defects in over 10,000 babies. So it's often said to be one of the reasons, it's a tragic event, but also one of the reasons for excluding pregnant women from trials. However, now experts today do argue that the exclusion can be just as harmful. And we'll dive into that in a moment, but then also when I hear, okay, you say UCB is doing actually that, I wonder, first of all, how did that start? Because you're one of the first pharmaceutical companies who's actually doing that. And also, how are you doing that then?
Yeah. So I want to say we're the first one to voluntarily do that.
Which is important. It's important.
Because you mentioned the must do versus do it. And I want to say something about this disaster, which is absolutely terrible, is that today, and what Dr. Kelsey put in place after the disaster was uncovered, is actually more preclinical data. So today, the way we develop our assets, our drugs, they go through a lot of preclinical data that didn't happen pre-thalidomide. And I think we need to keep that in mind. So we're still under this whole assumption and we keep talking about it. But the way we develop drugs today in preclinical is very different from what we were doing at the time.
No, absolutely. And
Thanks to Dr. Kelsey at the FDA. And actually the idea that we need to have this data up front because indeed pharmaceutical companies have been afraid of including pregnant and breastfeeding women in clinical trial, afraid of the liability. But I'm very happy to say, moving forward, we now have a report, fantastic report from the National Academies of Sciences, Engineering and Medicines that talks about advancing clinical research for pregnant and breastfeeding women and the difference between the real risk and the perceived liability and shows that actually by doing it earlier, we actually bring more data and we reduce the risk for the entire society, for all women. And this is what UCB understood
early
10 years ago when we started. So how we did it, first of all, by a shift in mindset internally, because we needed internally to bring everybody on that.
What did that require to get that shift internally?
Understanding the unmet needs. So we heard a lot from patients. At UCB, we listen to patients and we got a lot of women talking to us and explaining what they were missing, explaining your story about their pregnancies, what they were losing, what they were missing. Of course, I had my personal history, which also helped in developing that. So that was the mindset. And then we started generating data. We started looking earlier, looking even earlier than what was required to better understand what we could expect from our drugs and what we could expect from the disease that was, we were, thinking about the therapeutic area and looking at, what was the impact of pregnancy on this disease? What was the impact of the disease on pregnancy? So both ways. And with that in mind, the feedback from the patients, understanding and telling us what they wanted to hear, what they wanted to see. Then we started our first clinical trial. And what we heard, for example, is that for a woman, pregnant woman, placental transfer is critical. They want to know whether the baby is going to be exposed to the drug. So we started looking and doing a very control study, very, very robust study on placental transfer and breast milk transfer. We did both.
So what are some of the scientific and ethical challenges that you faced during designing these trials, including women of childbearing age in it?
So one of the first one is that women were saying it's not possible, it's not ethical. And the society is saying it's not ethical. And this is why today, with all the ethicists we're working with, we are saying we need to protect women through research, not from research.
Exactly.
And I think it's really important that we move into that direction. And we need to move from a paradigm of fear and exclusion to a paradigm of inclusion and empowerment.
Yeah, absolutely.
And empowerment is data. We need data to be empowered.
Exactly. I agree.
Yeah, we often hear that women are excluded from clinical trials for safety reasons, so protecting from research, especially during their reproductive years. But it's not just only during reproductive years. It's much broader than that. You have a deeper bias that the idea that women's bodies are too complicated, too hormonal, too unpredictable, to study it properly. That's the idea that there's created, that the complexity becomes an excuse and not a reason to actually include them in research and study them. So how can we change this patriarchal thinking in medicine that the women's bodies are too complex?
Oh, yeah, me. Okay. Absolutely. Give me all the patriarchal questions.
I know you love to debunk them, so let's do it.
I do. As a researcher, we are told that data is important. The way you collect data is important. Try and look, and especially in health psychology, try and look at your own biases and then the biases of your sample, of your cohort, etc., etc. What I find in my own practice is that it's important, but it's not enough. We need to have also intellectual humility, which is that we don't know really what we're looking for, or we don't know what is missing. And so we should have humility and just ask the people, which is the patients. We should have also intellectual curiosity when, as researchers and scientific, and especially in healthcare system, saying, again, I don't know, is something people don't want to say, is something people feel very uncomfortable with. And it's part of that patriarchal mindset where the doctor or healthcare professional is all-knowing. I don't want just to bash doctors. I don't want to bash anyone. I want us to work together. And so coming from a place of humility and a place which is I don't know is hard, which is also part of the mindset shift that we should have. And we should have also intellectual integrity, saying we were wrong about this and that. And I say that especially for the past 3 years, we've known that everything that we actually know about Alzheimer's is maybe or actually false. And that although research on Alzheimer's disease, why do I say that? Because for every man, 2 women are affected by Alzheimer's. And the first patient actually where Alois Alzheimer's, a German, got the disease named after him, which I think was also a big mistake, but whatever, was a woman. It was a farmer in Germany who brought her to hospital. He saw her, and then after she died, he did an autopsy on her brain, saw the plaque. And so the plaque theory of how Alzheimer's disease come to be has been the same theory since 1906. And we know now that women and estrogen and our own biology might be the missing link when it comes to advancing Alzheimer's research and possibly cure. And all that since 1906. It's 2025. We haven't met any progress because we started with something that was false and no one had the courage, and all the funding, public and private, went into that plaque theory, and no one had the courage to say we were wrong. And the few people who knew that, like biochemists, because it's not just doctors and biologists who work on disease, you have geneticists, etc., etc. All those who felt that the research did not add up, they were either shamed into not saying anything or threatened into not saying anything. And so that's why I think that also in research, in science, whether it's healthcare or something else, those 3 components of intellectual humility, curiosity, and integrity is important. And that's what we lack in healthcare a lot.
How do we get rid of that thought of too complex bodies to include? You have the menstrual cycle, you have etc. But okay, that's how the female body is designed. It doesn't give you a reason to exclude them.
Absolutely. So we start there, right? Sorry, Marie. First of all, it's a cycle. So we know more or less what happens there. And we know like the 4 phases. That's fine. If we feel, again, patriarchal point of view, if it's too complicated, then let's invest in that. Let's get to know more. Let's be curious about that. Let's see how it affects this and that. You were talking about the US. Do you know that FDA approved, so the agency that approves medication and drugs in the US, like over 86 medication in the US for cardiovascular health, anti-seizure, cancer. Like women have twice as much side effects than men because those medication were never tested on women. And when we say women, we think like human grown women. We're talking about mice, even like in the first phase, which is doing it on animals, unfortunately, and mice in particular, we already exclude female mice.
So a lot of things. We can talk for a long time about what has been done. And indeed, you're right. Not enough research. We can talk about the humility. Absolutely. It's important that patients in general, and I would say all patients, and women in particular, have the ability, the tools to talk to their doctors and ask questions. But it's true for all patients, maybe more specifically to women in some cases. But I think we see the changes happening. I hear your stories and I know the stories, but we also need to start thinking about, so how do we want to change it? Mm-hmm. And I think this is why UCB said, let's start doing research. Let's start bringing this information to patients. This is why NASEM did this report. This is why the ICH guidelines are being written right now and open for public comment on how to include pregnant and breastfeeding women in clinical trials.
How does UCB define inclusive research in this day and age?
Exactly that way. We actually talk to all. If a disease is a disease of women, we expect the same prevalence of the disease in the general population as in our clinical trials. We are in autoimmune diseases. We are in some diseases that affect predominantly women. Mm-hmm. And so in our clinical trials, we expect the same number of patients. And the way to help women getting there is to design the studies with them in mind, with them and for them. Mm-hmm. We see, and you ask about the pregnancy ones and how we did it. You know that when we design it, it was clear that you would be eventually with a mother, with a small baby, newborn, young mother, a newborn. How could we expect a mother to go to a visit, to take her car, if she has one, to take the bus, to take the subway, to go to a study visit, which is typically what you do in research. You need to have that time. You need to have that flexibility. So what we did is that we got external groups, nurses, were actually going to the woman's home and do the blood sampling that was needed and other tests that were needed so that the woman could stay at home. So keeping that in mind, which was not necessarily done in the past, where actually women would have to go to study visits for hours. That's just one small example, very practical. But that helps. That
it's
helps
important
patients.
to keep that in mind because inclusive research or in designing inclusive trials, etc., it's not just including women in it. There are so many different layers, different groups of women, the socioeconomic background, ethnical background, etc., that do play a role. We actually dived a little bit deeper into that with Sarah Ahanak in another episode because they designed also for the Isala project. It was specifically for women, the project, only women, as they studied the vaginal microbiome. But at the same time, it was also the same demographics, the same population of women, and they were like, even though it was just for women, we had to go a step further to make sure that there was a diversity on all aspects in that trial, in their research. And if I may cycle back then to when we're talking about research, to the testing on mice, where we're talking about diseases that predominantly affect women, yet there are male mice used. Even if, we have female mice used, I liked what you mentioned about that, Maha, that still you cannot necessarily extrapolate that to real life because the society that's built around us has a huge effect that you can test in a lab.
Absolutely. So I'm going to go to that, and I like what you said about sending nurses to, because the attrition percentage, which is the number of people who drop out of a study, depending on what you're looking at, yes, people drop fast, and especially I imagine young mothers. Because actually, yes, when you are in a lab and we see that in heart disease medication, doctors are like, but patients, they don't take their medication the way they're supposed to do it. And if they would take it, then they would feel better because we have the results, we have the science. And you're like, yes, but people are not mice. And in a lab, the way also medication is designed is that you go, you take the mice and you inject it every day at, let's say, 10 o'clock. Mm-hmm. It's not 10:01. It's not 9:59. It's at 10 o'clock. Real life doesn't work like that. And so also in the way we design the research. That is something that needs to be kept in mind. I was in that talk with a cardiovascular doctor who was saying, like, at first the patients, they will take the medication because, you know, you almost died of a heart attack, right? So you're being careful, but then you feel better. Maybe if you've changed your diet a bit, maybe you've started also exercising, you feel better, and then you don't take the medication anymore. And especially women. And she was surprised. But again, it's the side effect thing. When we had the conversation, I told her, patients, when we start medication, and I am one of these patients, I did ask to stop cortisone because it was driving me crazy. Literally, you do stop because of side effects. And so again, we go back to research, inclusion of women of all age, of all background, because the way that then this medication, which is supposed, how can it be life-saving and life-supporting if you don't take it anymore because the side effects are what they are? And sometimes it's like because you don't take it at the right time. Again, it shouldn't be a question of time. It should be a question of, is it designed the way it should be designed for real life, for outside of the lab life. And for inclusion in research, I love what you said. Again, I have a lot to say about research, right? Because I co-founded a research group made up of patients, and we award up to 90,000 euros to research groups. So it can be biology or social sciences, etc., etc. But one of the main criteria is that was it co-designed with patients, and what is the role of patients? Are they only like objects? Are they subjects, which is a step better, but are they co-investigators, which is kind of the growl right now when we talk about research. And so I think that that's the way forward, right? For some things, you can't include patients, but wherever we can, this should definitely be the way forward. So you know how you live your life outside of the lab. And so when it comes to side effects, but when it comes also to taking the medication, then we can have even better design, because maybe you're a young mother and you can take your meds only at 8 o'clock at night, because that's when all your kids are in bed.
And I think absolutely. And I think this is really important to keep this conversation going on with the physician. So beyond the research, it's also being transparent. And often patients do not have really the tool, the know-how to talk to patients and explain to physicians and explain why they need to do it that way, or just say, this is how I do it, and this is what I do. Because then the treatments can be adapted to that. But to your point about doing it with patients, with women, in that case, I'm going to jump to Bridge.
Because the
Mariam,
Bridge
right?
is, moving the needle a bit, if we may say so. You co-chair Bridge, and what I'm curious about is how is that helping to change the global norms around inclusive research?
Yeah. So very interesting, because it's the perfect link here. So Bridge stands for Better Research, Information and Evidence Generation for Empowerment of Women with Chronic Diseases. So we say Bridge because really...
Please and thank you. Please and thank you. Let's talk about that.
So it's an independent group. What is specific about it, and when we talk about inclusive research, is that it's global. We have women. It's a group of women. Some men joined us, because I think it's important to have men
Absolutely
included in that. And there are patients from Africa. They are leading patient group. They are advocacy. They are physicians. They are ethicists. They are regulatory authorities, scientists, or former regulatory authority scientists. And we all work together on empowering women. And what is very specific is that it's co-chaired by a patient. And it's co-chaired by a patient who was pregnant, has a chronic disease, was pregnant, and was entered in a study during her pregnancy. And so with that in mind, you see the different mindset. We start from there. We don't start from What is the science behind it? What is society thinking about it? What are the regulators thinking about it? We start with what are the patients thinking about? What do they want? What do they want to hear? How do they want to be empowered? Because we believe that decision making should be shared decision making. And it starts with women's health taking their own, fundamental rights of healthcare in their hands and making it happen. So that's Bridge. And Bridge issued a report that brings these recommendations led by patients, physicians, regulatory agencies, policymakers. What is the recommendation? What type of funding do we need? You mentioned funding earlier.
Are there any key findings or one key finding that is interesting to share?
The key finding, I think we both said it earlier, is that we as patients do not know how to bring the information. We do not know how to get the conversation going. And if the physicians are not bringing it to us, we don't know how to do that. This is also why UCB developed tools, discussion guides for pregnancy and breastfeeding to get there.
It is very important because you don't know what you don't know, and you can't really start a conversation of, we heard it many times on the podcast, like it's a new market, when we were talking with the innovators, when we were talking about policymakers, like you have to be vocal about it so we can have more laws, etc. But you need to be educated on the topic to be vocal about it. If you don't know what to be vocal about, if you don't know that these are the symptoms of heart attacks that affect you predominantly than men, or that you have higher chances of developing that in this case, then you cannot be vocal about it. So it's really important, as you said, the conversation starters, but so it comes all together to the educational part.
Absolutely.
If we don't know what we don't know, then we cannot have those conversations.
You are absolutely right, Mariam. And I want to add to that, which is a great point you're bringing here. It's how to make the data available, because there are some data, because there are registries that include women, because we have some of it, but how do we make it available? And that's what Bridge is also one of the recommendations that came out, is that we need to work further on the availability of data, the awareness, as you were saying. And sometimes these data are not straightforward. They need to be analyzed. They need to be interpreted. And this is what also Bridge is working on. So it's hopeful, actually, if you look at the times that we're living in, because there is also more conversations going around women's health, and that awareness is building up. Do you see also a momentum building, Maha? And in which direction do you think it's going?
I think it's going in the right direction. As I said earlier, I'm also a political journalist. And so for us, political journalists, it's all about also agenda setting in the public sphere and what we talk about in the media, but also the kind of conversations we have between friends, etc. And right now, talking about women's health, and that's also why we're here today, right? You have this podcast, I have mine, is something that we can talk about, actually. But like really talk about, dive into the data, the science, and, well, in the case of my podcast, more personal also stories, which are actually that I take from an epidemiology point of view. It's not just stories for the sake of stories. It's really like they say something. And so agenda setting is important. And when, as women, we use our voices, because again, in a patriarchal society, we are expected to be seen, just like children before, right? Last century, children should be seen, but not heard. Well, for women, it's the same thing. And also, please, under 50 or before your menopause, after that, just get on the side of the road. We don't want to deal with you anymore. And so now, thanks to the media, social media, being able to do a podcast, not having to go through the regular radio, channels, etc., we do have the tools that allow us to have those conversations, to know what is happening to a woman in Saudi Arabia or Pakistan or in the US. I mean, come on. And so because all of that is still happening, still 2025, to us, it opens doors to those very important conversations, that stem from what happens when you have an autoimmune disease and you are pregnant, which is also a conversation I had to have with my doctor, whose idea was like, get pregnant. It might reset your immune disease. It does. But I was like, this is not what I want to talk with you.
Always.
Yeah.
But sometimes.
But so I have a lot of, hope because we are speaking up. We are making our voices heard, which is the main issue with women in the healthcare system. That's why sometimes as a woman, you go to the emergency room, you are having right now a heart attack, and we either send you home or it takes from 30 minutes to an hour to have the proper care, although you are in a hospital setting surrounded by healthcare professionals. Agenda setting again. Every October in France, in Belgium, in the US, you have Pink October, right? Breast cancer. And absolutely, we need to fight for that and to do that. But breast cancer is the 8th cause of mortality for women when it comes to health in the world. First cause are stroke and heart diseases. So let's talk about that. Let's do something about that. Let's research that also. And we're not just like, that's, in France we call it the bikini medicine, right? Which is always
focus.
about, So let's move beyond that. And I think that definitely we have now momentum for that because we are more and more women using our voices to address the specific issues. Like I said, I went from being a geopolitical journalist to now being a health researcher and hosting a podcast about women's health and trajectory in the healthcare system.
That's actually one of the reasons why we dedicated a full episode on cardiovascular disease, heart disease, because it's the number one killer. And it's something that we should be aware of, know, so you can be your own health advocate. You have to know what affects you.
Exactly. And I think the political agenda is getting there. We see that. I need to talk about the Conception Project, which is an IHI project. Actually, IMI at the time was IMI, was launched in 2019, and it was really looking at safe and better medicines for pregnant and lactating women. And so, and IHI is really looking at projects and evaluating projects on women's health. I agree. In the past, we were looking mostly at reproduction, right? You're talking about breast cancer. We were talking about, although not all of these diseases are resolved. No. Endometriosis, and others that we can name. I think what we have learned over the years is that we need to think about these diseases that affect the general population, which includes 50% of women. Women lifestyle have changed, which wasn't the case. Women are now, for the last many years, have been active, working, stressed, on hormonal therapy, smoking, drinking more because they have the active life that maybe 100 years ago they didn't have. So of course with that are coming more diseases of the men that we didn't study. We didn't look at that. Because at the time, women were less prompt to these diseases. Now, for the last 50 years, we need to look at them because now we know women have the same lives. Everybody is working the same way. Everybody is stressed. Everybody is running. Everybody is, doing their activities. And in addition, women have the hormonal changes and the physiological changes, biological changes that men do not have. So we need to rethink
that men do not have.
mental load.
Why do we drink and smoke?
And so how do we change the way? And I think it's going to take time, but we see that happening. We see research going into that direction. So my hope is that in the future, we will have, in the near future, and we start seeing that, we better understand heart disease. Now we need to talk about how do we make women aware, as you said. How do we make sure they're not missing the point? Because for a woman, a heart attack may not be chest pain. Absolutely. It may be nausea. It may be fatigue. And this is where we miss it. So we need to raise more awareness about it, which you're doing, Mariam, but it needs to grow. And there are a lot of other diseases where we need to bring this information to patients, but we're getting there.
We're getting there.
And there's a lot of hope.
I would love to get to the hopeful part about looking into the future. But maybe before doing that, I just want to quickly ask Maha if, we talked about autoimmune diseases a lot, chronic diseases a lot. I don't know if, and chronic fatigue, endometriosis, fibromyalgia that we talked about, that all these things are dismissed as psychological. First, is there anything else you want to elaborate on that part?
Fibromyalgia, that I developed because of sarcoidosis and all those autoimmune diseases, we need to have more research on the immune disease of women. We know that it doesn't work the same way. Men's autoimmune disease, men's, the men's one. It doesn't work the same way, and we need more research into vaccine, for example. I mean, when we say we need to invest more and include more women, it doesn't mean that we have to redo the whole enchilada. We already have vaccine research, right? There's already a lot of money going into that, but we know now also with patient-reported outcome that women might actually need less of a dose when it comes to vaccine. So how about a little bit of the money that goes into vaccine development is also dedicated to that, studying the immune system and response of women. It's not about, because sometimes when you say we need to change things, we need a paradigm shift, mindset shift, what people hear is that we are going to burn it down. That's not what we're talking about. What we're talking about is inclusivity, is programs like Bridge, because I can't imagine you are a woman, you want to have a kid, and you have to choose between medicine for your heart, your chronic heart disease, or your autoimmune disease, or keeping the pregnancy, let's say, or even thinking about the pregnancy. I can't even imagine being in this kind of situation. So what we are saying is that let's expand again. Let's be curious and let's tell those stories. Why? Because I think it's Steve Jobs who said the storyteller is the most powerful person in the world, right? Because what do stories do in all societies? You said it's inclusive of all continents, of all societies. What stories do is that they show you the scaffolding of whatever institution or brand or action is happening, right? And so the story can help you see beyond that. And so hearing women's voices, women's stories, which again, I'm trying to do with the podcast, is also about when you tell those stories, you also decide where the money goes, what is heard, what is accepted, what is rewarded, and what is shunned. And so right now, I think we can be really hopeful because we are making it happen. It's not just like coming from above. We are making it happen as women, opening conversations. And also one of the conversations should be how do we reallocate some of the already mobilized funding into looking at very specific gender-based biology. Yeah.
Absolutely, especially considering, and you're talking about autoimmune disease, which I think we know today that over the last 3 years, data have shown that there is an increasing prevalence. Depending on the study, 3 to 10% increase in prevalence. So imagine where we are going. Multiple sclerosis, disease of women, autoimmune disease, high prevalence in women, plus 30% over the last years. How are we going to manage that if we do not have the data? So really important to continue the message, to continue what you're doing and say, we need all to be part of that. If every woman who gets pregnant, as an example, is giving data to research, we will learn more because women have been treated with drugs. This is how we know there are side effects, right?
Absolutely.
This is how we know because of registries. So let's start with mining the data and producing more data.
And to because there is so much that we can discuss on this topic, I think, and then
we can stay here all week.
Yes.
But to end on a hopeful note, as we all wanted to, looking forward to the next 5-10 years, what progress have you seen that's been made that gives you hope?
So I want to talk about tech for good, as we say, and a little bit about AI. Not that I am particularly hopeful when it comes to AI, because the way AI works is that you have real world that produce data, and then those data sets are put into the machine, and then the machine, people use it, and then there's extrapolation, and this feedback loop is what is actually making biases even stronger. However, there is an opportunity there when we talk about data sets. So if we address the conversation about AI, I think is interesting, because if we address those bias in AI, not just shunning AI away, but saying, okay, so real world is full of biases. We see it in the data, then we feed data to the machine. And so obviously the machine is going to be biased. So let's, from the start, from the beginning, try and give it less biased data, right? And the way we do that is by having, I believe, an integrated care approach, which is you have all stakeholders at the table. Women, men, pharmaceutical companies, healthcare professionals. Earlier we were talking about patients, caregivers, but healthcare professionals, they are part of that. I also teach at medical and pharmacy school. And those young people, really, they give me so much hope, because I go there and I talk to them about what it means to be a patient, and they are interested. Usually when I have their feedback at the end of the year, when they have to grade lectures, because now it's the way it goes. Everyone wants to grade, give 5 stars to everybody. Every time they tell me thank you, and I hope that you're there next year, because I've learned so much and I want to be a good doctor. I want to help people, and I teach them day one, you don't save anyone. People save themselves. Even as a specialist, if you see a patient like 3 hours a year, it might be the maximum. When patients, we take care of ourselves daily, all day, every day, 24/7. So we do save our own lives. Your job is to help us do that and give us the data we don't have, and give us the orientation we might not have or time to look for. That's your job. And they listen to that. And sometimes I like to also skulk around in at the hospital, and I listen to them talking, those young doctors, and they tell you how they're shocked that this professor or that professor talked to that patient that way. And so it's working. It's working. And as you said, we need to go at it from all angles and keep the conversation going without shaming anyone also. I think it's very important that we also do that work of, we can deconstruct things without having to shame anyone. I know I'm a lot like the patriarchy. It's not about shaming that, because it's a system. It's not about shaming people. And I say that in the podcast. It's not about shaming doctors or healthcare professionals, because they were raised in a certain system. And so you internalize that, but it's okay to address that with the stories, to see what is behind. And then when we see what's behind, then we can act. We need to name and understand a problem to act on it. And I think that what we're doing right now, and this
it's a collective approach. It's a collective responsibility.
Absolutely.
So, it's a collective responsibility. And I think we all have a role to play in bringing that systemic change. It's not one group of people. It starts with you as an individual, but it also comes to being an advocate for certain things, and also knowing how to build bridges between different sectors, between different groups of people, etc. So thank you very much also for sharing that message and the work that you are doing. And one last hopeful message from Marie.
So very much aligned. Collaboration. This is the only way. We cannot do it alone. None of us can do it alone. We need to do it together. We need to hear all the ways of thinking. We need to look at all the data, which hopefully AI will help us to a certain, somehow, hopefully. And my last word is going to be the word that I want everybody to remember we need to protect women through research, not from research.
Thank you very much, Marie, for that message as well. Thank you, Maha. Thank you, Marie, for sharing your inspiring and very interesting thoughts and for helping us to spread the message and educate our listeners as well. Thank you to everyone who listens to the Women's Health Uncovered podcast. Please do let us know what you think of each episode, because we're really curious to spread the message with you along, because as we said, it's a collective responsibility. Thank you, ladies.
Thank you very much, Mara.